and I'm going to pass you directly over to Rob Semple, who is in Edinburgh. And Rob will introduce himself, and he's going to be talking about the Alström mouse. So over to you, Rob. Thank you.
Thanks very much indeed. So can you hear me okay, Tim?
Yes.
So it's always a pleasure to join this group. I am going to talk about the mice a little bit, but not just the mice. So just to explain who I am a scientist, but also a doctor. I sit in diabetes clinics sometimes, endocrinology clinics sometimes, and for many years I've been interested in all sorts of inherited conditions, genetic diseases, including Alström syndrome, which cause severe insulin resistance and all the types of problems you've just heard about. And so I'm going to cover some of the same territory, but from the particular angle of that experience of other conditions. And I'm going to try to avoid any scientific or clinical language as best I can, but no doubt there'll be a few things which will creep in. So I'm going to start off again, going back to this issue of fat tissue and obesity, because I think it's really extremely important for lots of the problems in Alström syndrome. And I think that can't be emphasized enough. And I'm going to start off with some slides which I use when talking about commoner diseases, obesity generally, and then a group of diseases called lipodystrophies. So I sometimes share this slide just to remind people that we worry about obesity in the general population. So this is true for all of us on this call, because it is associated with not just diabetes, but also reduced fertility and damage to the liver and heart problems, and also in older ages, increased risk of cancer. So obesity now is thought to be the second biggest risk of cancer, acquired risk of cancer after smoking. But it's all very well saying that, but why is obesity linked to all these things? What is obesity? Well, obesity, remember, is just too much fat in the body, and fat is just horrible yellow gloopy stuff. You see the picture of some fat on the left there, and then on the right, I show some fat under the microscope, and you can't see very much under the microscope because fat is made up of cells which are like balloons full of oily lipid held together with tiny little structures. Literally, it's like a lot of balloons packed together. Now, if having too much fat is bad for you, what would it be like if you weren't able to make fat tissue at all? Wouldn't that be a really good thing? You could never be obese, and so surely you would be very healthy. But actually, and this is one of the major conditions I work on, we work with a lot of people who aren't able to make fat because of conditions called lipodystrophies. These aren't Alström syndrome, and often they're so severe that it's not possible to make any fat at all. So when people have these conditions, they look very muscly, very thin, very athletic, but they're not at all metabolically healthy. And in fact, the pattern of problems they have with metabolism is almost identical to what is seen in Alström syndrome. So they get diabetes very early on, often childhood or teens. They get very high fat levels in the blood, very high fat levels in the liver, with scarring, which happens just as early as in Alström syndrome as well. And because of all of this, there is a risk of the things that we really worry about, which is narrowing of blood vessels, heart attacks, heart damage, and liver damage, and the like. So this shows that it's not actually just having too much fat which is bad for you. It's having fat which isn't working. So this is how I summarize how our bodies regulate these things. So whether or not you build up extra fat and become obese is really controlled by the brain. And that's because the brain controls our appetite and how much we eat, and also some of how much we burn. And we're all made in different ways. Some of us enjoy eating more than others. Some of us have energy burning pathways which are more than others. So if you're in the right environment and have the right brain, you build up more fat and you gradually become obese. But that doesn't mean that you get unhealthy, because if you can carry on making fat, lots and lots of fat, lots of healthy little balloons of fat in the body, then you get bigger and bigger. And there are some problems which come from being very big, pressure on the joints and such like, but you don't get diabetes or fatty liver or insulin resistance. But as soon as you reach the limits of how much fat you can make, then the fat gets damaged. It gets overloaded and it gets inflamed, and it causes all those other problems, including insulin resistance. And when your body isn't able to make enough insulin, you become diabetic as well. So it follows from this that all of us are different. Some of us in the general population are able to make lots and lots of fat healthily. So we can become very obese and never have metabolic problems. Other people, through plain bad luck, aren't able to store very much fat. And as soon as they get to the limits of that, they become diabetic and all the types of problems that we've talked about. And in the severe cases, this happens even in thin people, well below the overweight threshold. So one way I like to try to explain that is that imagine your fat tissue like a reservoir to store water. If you have a very large reservoir, as in this top picture here, and only a little bit of fat storage, you can store lots more fat or water without any problems. But eventually, however big the reservoir, it's going to be possible to fill it up until it overflows, it spills over and causes problems. And when eventually it overflows, that puts fat into other tissues and becomes unhealthy. So how do any of us know how big our fat storage capacity is? Well, mostly we know that by looking at our families and seeing if people in the family have diabetes. And in the case of Alström syndrome, the problem is that the reservoir seems to be particularly small. So it's in some ways, it's not really anything to do with obesity. Of course, people with Alström syndrome often carry some extra weight and could be classified as having mild to moderate obesity, but that's not really the point. The point is the fat is not working. It's overloaded and not able to do its job. And it's not just about how much fat you have, it's about where the fat is. And there's the ideas of apples and pears. So people who put fat in the middle of their bodies tend to be less healthy than the ones who put them in the hips and legs. So this is my last general slide. And this is very important and a little bit optimistic as well, because even if you've got one of these severe conditions, which means that you have the bad luck to have fat tissue which can't store lots of energy very well, this doesn't matter if you're not trying to store lots of energy. So in other words, just because you've got gene changes, which could be Alström gene changes or something else, which means that it's very easy for you to get diabetes and fatty liver and all those other things quite early on. That's not inevitable. And if you can stop trying to store fat in your fat tissue, you will dramatically be improved. In fact, even people who make no fat at all, if they are very good at following a very restrictive diet, they are entirely metabolically healthy. So it's not that you're stuck with these problems. It's just that it becomes much more important for you to imagine that you're very obese, even if you're not very obese, if you like. And so I tell a lot of my patients with problems with fat tissue this, you can sort of ignore all the guidelines about BMI and which treatments to use at which BMI, because these are all about the general common population. If you have a condition where you get metabolic damage, even at low BMIs, you can forget all that stuff. And it won't be in the license and it won't be in the product literature. But it makes sense for you to be using obesity type treatments, even though you were thin, as long as you have evidence that your fat isn't working. But because you take these treatments off license, that's where it's important to be supported by doctors and specialist services who can advise you on the risks and benefits and take responsibility with you for that. So Sadaf nicely explained why this is important in Alström syndrome. So Alström syndrome, I think, is exactly one of these conditions. It's a condition where, although there is some increase in the fat tissue, if we look in the fat tissue, we can see it is overwhelmed. It is damaged and inflamed, and it's not able to do its job. And so, in fact, maybe, although the gene change in Alström syndrome is present all over the body, maybe it's the change in the fat which is causing a lot of the other problems. So we, excuse me. So we study mice. And why do we do that? Is that just because are we just indulging ourselves out of scientific curiosity? Well, no. I mean, I don't think anybody really likes studying mice, but studying mice can be incredibly valuable to accelerate how quickly we can understand and make new treatments for rare conditions. And that's simply because there just aren't that many people with Alström syndrome in the world. So if we're thinking about lots of different types of possible treatments, there aren't enough people to do all the possible combinations of trials. So if we can use mice which live for 3 years as opposed to people who live many decades, then we can make progress much, much faster. And of course, we can also always investigate what's happening in the tissues of mice to understand what is going on there in a way that we can't, because we can't biopsy lots of tissues in humans. And many people over the years have made mice without the ALMS1 gene and shown that in lots of ways they look like people with Alström syndrome. They do suffer visual loss and hearing loss, and they do carry extra weight, and they do have insulin resistance and fatty liver and diabetes. But there are still some important things we don't know. Nobody has ever really described what the hearts of these mice are like. And the other thing we can do in mice is we can take away the gene from only some tissues, which will help us work out which tissues are most important. So in the last 2 or 3 years, we made our own version of mice with no ALMS1, and we found they were the same as the other ones which people have reported. So our mice have a higher appetite, which means they put on more fat. They become very severely insulin resistant with high fat levels in their blood and in their liver. So they produce all the metabolic problems which you've heard about in people with Alström syndrome, which you know only too well. But we thought that this might all be explained by problems in the fat tissue. So then we made some other mice where we took away the gene only from the cells that make fat tissue, and a few other cells in the body as well, but mostly just from the fat tissue. Because we thought if this is really about the fat tissue, then these mice should have all the same problems. Now, don't worry too much about these pictures. I just put them in there to make some color. But that's exactly what we found. We found that even if we only take away the ALMS1 gene from the tissues that make fat tissue, essentially all the same metabolic problems happen, proving that it's the fat tissue which is important for lots of other stuff that happens in the body in Alström syndrome. And that includes the liver. So for example, we know that there is a problem with liver fat accumulation and then scarring. But in fact, our study suggests that's nothing to do with there being a problem with the liver. It's because the poor old liver suffers because of all the extra fat it gets delivered to it, because the fat tissue isn't doing its job. And there were 1 or 2 other interesting things we saw as well. We saw that the mice eat more, which is well known. But then when we left the ALMS1 gene in the brain intact, in the nerve cells in the brain intact, the female mice still ate more, which was very unsurprising because previously scientists have suggested that losing the ALMS1 gene in the brain, in the nerve cells, makes you more prone to eat. But our findings suggest it's not just about the nerve cells, it's some other nerve cells. And we're going to be pursuing that too. So as far as the metabolism is concerned, we know, in keeping with what Sadaf was saying, that lacking ALMS1 in fat cells is enough to cause nearly all the metabolic problems in Alström syndrome, including liver problems, even though the liver is normal. So it means we have to think of Alström syndrome as featuring fat failure, just like it's equivalent to heart failure. And it's not just to do with obesity, it's to do with the fat not doing its job. Now, importantly, we also see that all these complications occur with almost no scarring. Well, the medical word for that is fibrosis in the tissues. And that suggests that trying to target the fibrosis probably isn't going to improve those problems because they can all occur without any fibrosis happening. And that's one of the ways in which the mice are useful, because that's one possible strategy which has been thought about and even tried in humans. And there's also lots of inflammation, which means immune cells coming into the damaged fat tissue in Alström syndrome. So, and that's true even though the immune cells themselves are normal. So that is caused by what's happening in the fat tissue. It's not the cause itself. And that tells us again what to study. And the other thing we want to do and just to summarize that, I think we haven't suddenly come up with a new treatment, but we have added a lot of evidence to say that using all the obesity treatments out there, including semaglutide and all its related compounds and the better drugs coming along, makes a huge amount of sense. And everybody with Alström syndrome who has insulin resistance or a fatty liver or high fat level should think of themselves as, if you like, being obese on the inside. And their doctor should support them in getting access to treatments which are usually only used in obesity. Now, very briefly at the end, we were very, very keen to study for the first time if the mice with no ALMS1 syndrome also had the heart problems, which are such a worry in Alström syndrome. And nobody's really studied this properly before. So we took our mice and we did heart ultrasound scans, heart echo scans in infancy, when the mice were 8 weeks old, which is like a teenage mouse, and when they were 24 weeks old, which is when they're in their 30s, because we were quite excited that if we could find abnormalities in the heart, then we can really start studying the heart carefully and start developing new ways of treating the heart failure. But we found that there's no heart failure in infant mice, no heart failure in teenage mice, and only the earliest signs of heart failure in the 30-year-old female mice, if you like. And again, I'm just showing some pictures which we use to demonstrate that. So for some reason, the mice are not good at copying the heart failure of Alström syndrome, even though they have diabetes and obesity and insulin resistance and raised liver fat. So maybe mice are just different. Maybe mice are simply no good to understand this. But they might also be giving us clues, because the mice don't get much scarring or fibrosis, and they're also not very good at narrowing their blood vessels like humans are. So maybe this is telling us that it's the scarring which is important in the heart. I told you it wasn't important in the liver or elsewhere, but maybe it is important in the heart. And maybe being able to narrow the blood vessels because of the insulin resistance and diabetes is important as well. So these are ideas that we're going to follow up in the future. So sometimes negatives are useful as well as positives. So I'm very happy to answer any questions about any of that. I've hopefully just mostly backed up what Sadaf told you. I just wanted to highlight in particular Eleanor, who was a British Heart Foundation sponsored student in my lab for the last 3 years, who really has done all the fat work that we've described. And we're currently looking for more funding to take that further. So I'll stop there. I'm very happy to take questions.
Thank you very much, Rob. Thank you. We've had some questions in advance that I'd like to ask you, please. And some of these questions will link also to Pietro's presentation a little bit later, but some of your thoughts on it too would be helpful. So the one question that came through was, is there a kind of best strategy to lose weight?
So again, that's where proper trials are needed. So I can tell you what I think based on everything I know. And when you talk about rare diseases, often you have to make decisions in advance of trial evidence. That is just the nature of the world. And if we wait till there is rigorous trial evidence and licensing in, then you wait forever, and that's no good. So I think actually there's probably no difference to people with metabolic complications in Alström syndrome and people with the same metabolic complications because they are severely obese. So in other words, I would simply consider, if I was advising a patient one-to-one, all the best treatments that we use to try to encourage weight loss. So that would include semaglutide and all the related medicines. It would certainly include all the best dietary advice. And, you know, I should say this is from my experience in lipodystrophy. Even going up as far as bariatric surgery, in theory, makes perfectly good sense. But most systems of care will not allow you to get access to a lot of those treatments because they will be applying the rules that come from common types of type 2 diabetes. So you need your doctors to discuss with you the pros and cons and make the case to experts. So among the types of medicines that you heard Sadaf talking about, those semaglutide-like medicines, GLP-1, those should be excellent. What we call the SGLT2 inhibitors, the flozins, are also very good medicines for diabetes that also help weight loss. And good old-fashioned metformin is very good as well. So those would be my 3 tablets of choice in anybody with poorly controlled type 2 diabetes or one of these lipodystrophy-like conditions. But I would also be trying to persuade my expert colleagues in obesity to give people access to those approaches, even if they were thin.
Okay, thank you for that. So another question is, would you recommend actually taking any supplements? And in this instance, kind of thinking more around vitamins. I think it was during COVID, lots of our folk with Alström had vitamin D, if I'm remembering right. I'm sure Kerry will correct me a little bit later. So do you advise people to take any vitamin supplements?
I think most people probably should take some vitamin D because most of us in the population are a little bit vitamin D deficient. There was a lot of interest during COVID that might be something to do with susceptibility to COVID. But no, I would give the same advice I normally give. If you're going to take supplements, there's not very much evidence for many supplements at all. So number one, check with your doctors that you're not going to do yourself any harm. After that, whether you do yourself any good is very uncertain and we don't really have evidence. But as long as you're not doing yourself harm, that is up to you. I think that's the best I can say.
Okay, thank you for that. And another question, which is, I think is a concern for many parents, is this stuff around appetite. And we certainly, even anecdotally hear from parents who feel their children have this really increased appetite.
Yeah, and I think that is a real part. So if you like, it's a double whammy. Because if you have fat tissue that is not very good at storing energy, the last thing you want to be doing is eating more, which puts more pressure on your fat tissues. So there are two sides of this. And that's where some of the observations we've made in the mouse push us in a slightly different direction to where we've been before. There are a lot of genetic types of obesity directly caused by very strong increases in appetite. And there are some trials to help with appetite, which are a bit further advanced than those. So right now, I don't think there is a single particularly proven treatment which helps that side of things. But I think we can be optimistic that the lessons we learn from the whole range of genetic obesity conditions will get us there a little bit faster than some other things. So I think gathering that information is very valuable, because it's quite difficult to document increased appetite. So sometimes in the very severe childhood obesities, people describe children getting up to raid the fridge at night and all sorts of things. And it's actually very useful to make sure that some of those observations which parents can make are captured somewhere on a registry or a database, because if it's not there, it can often be overlooked by researchers.
Yeah. Okay, thank you for that. And one final question, which in many ways, we've certainly seen some of our folk, particularly our older teenagers, early 20s, and we have some great examples where they've really increase their exercise substantially and kind of reduce some of the calories going in, and we've seen some phenomenal results. But this question will link to Pietro's presentation too, but it's a straightforward question, which is, does the heart get tired when you're working out?
It doesn't cause damage. So I think the reason for heart problems in Alström syndrome are not through overuse of the heart. And I think in general, maintaining fitness and burning energy is actually very important for well-being as well as for metabolism. So unless you know that you have heart trouble, in which case you should get advice from your doctor about exercising, I think sensible exercise is a very good thing. Just to pick you up on that other point, it's incredibly common, not just in Alström syndrome, but in all people with all these conditions. Teenage years are very difficult times for metabolism, partly because teenagers are teenagers and will do their own thing and resent being told what to do, certainly by their parents, but also because there are lots of hormone changes which happen during about the age of 10 to 20, which make insulin resistance and all these things worse. And so that starts to get better in the 20s. And then also often people decide to take ownership of things themselves. And so I think it's a mixture of those growing up behavioral things and true hormonal things, which do make things much better. So I sometimes also say to people with conditions like this in their teens, these are the rocky years, and actually just naturally without you doing much more, things will get a little bit better once you get into your 20s. So I think that's worthwhile saying as well.
Okay. Yeah, and thank you for that, because that touches again on Tim Barrett's presentation a little bit later, who will talk a little bit about puberty. Okay.
I can't solve teenagers, I'm afraid.
No, but we must remember we have all been teenagers. That's perfect. Thank you so much, Rob. Really, a lovely presentation. Fantastic to see you. And I suppose from all of us, keep up the great work. Really is appreciated.
This is a two-way enterprise. Remember, we're all doing this together. And the nice thing about research in rare disease is the people who pay for research almost won't be very interested these days unless you can show that you're doing it together with the people who are affected and have them behind you. So it's absolutely terrific having ASUK and all their international partners involved.